Good evening, Monday, February 11, 2019. What is Dr. Soloway doing sitting in the office at 6:30 on his birthday? Doing what I love the best and the most, taking care of patients. We had a full load of patients today. New patient with relapsing polychondritis. This gentleman is a very interesting case. He has auricular chondritis for many years, both ears, frequent recurrent episodes, poorly treated in the past. He has interesting findings of narrowed ear canals. He also has, excuse me, you guys always get me when I'm exhausted when I'm giving these videos. So he had narrowed auricular canals. He had a serous discharge from his left ear, which has been thought to be an infection. More than likely, it is simply part of his relapsing chondritis and the small canal. He's probably had the disease more than 20 years. He was treated with low-dose prednisone and methotrexate, never really had good follow-up, never had biologics, never was offered or asked about cyclosporin, Imuran, Remicade, tocilizumab. There are studies that both Remicade or infliximab, which I have used in my other relapsing polychondritis cohort, which is now, I guess, 8 patients. Remicade or infliximab works great. I guess if I have an infliximab failure, I'd be using tocilizumab, which is the IL-6 inhibitor. I'm certain you're all aware of that drug. If you're not, you just heard about it here. And this gentleman also has polyarthritis. He has no necrotizing scleritis. He has no rash. The reason no rash is important is when people with polychondritis have a rash, they actually have about a 90% predicted value of developing myelodysplastic syndrome. In fact, also, polychondritis, as you're aware because you've seen my video from the Congress of Clinical Rheumatology, or I think it's called that. When I presented a case of relapsing polychondritis in a gentleman who had unilateral auricular chondritis with necrotizing scleritis, who also then presented with fevers, constitutional symptoms, and bivalvular disease. He lost his aortic and his mitral valve simultaneously and died of heart failure. But interestingly enough, he never had tracheal involvement, nor no known lung involvement. That's never been described in the literature, only by yours truly. So that's a little update on relapsing polychondritis, and I only bring it up because it was interesting today. In addition, I reached out to my buddy Dr. Gabriel, who called me last night to consult me on a patient who is in a local hospital with pleuritic chest pain or pericardial chest pain, and this patient has a history of rheumatoid arthritis, and I was asked for advice on how to treat the patient. So, first of all, what you need to know is that pleural or pericardial disease is seen commonly in lupus, rheumatoid arthritis, scleroderma, to name a few. If you have a patient with polyserositis, which would be, at least in the chest, pleural disease as well as pericardial disease, if that patient does not have tuberculosis or cancer, that patient has lupus. If the patient has just pericardial disease or just pleural disease, particularly left-sided rather than right, or perhaps bilateral, That can be seen in lupus, of course, but that also raises the opportunity for it to be I'm sorry, not ankylosing spondylitis. I'm tired. And my eye is itching me. Maybe I have necrotizing scleritis. Rheumatoid arthritis and scleroderma are associated with pleural and pericardial effusions and restrictive pericarditis and tamponade and so on. The moral of this story is that if you have a patient who has pleural or pericardial fluid in the setting of the autoimmune disease, the treatment would not be colchicine and not really NSAIDs, but steroids. People always seem to try NSAIDs first, and if they don't work, which they usually don't, switch to 60 milligrams of Solumadrol for a few days, and you'll quickly eliminate the problem. The cardiologists like using colchicine in non-lupus pericarditis, and that's fine, except I don't like using colchicine as it is quite toxic, and I've seen many significant side effects such as neuromyopathy on several occasions. And finally, I had a request to make a little video here on ankylosing spondylitis from one of my followers here on YouTube, I believe. So what I can say to you tonight about ankylosing spondylitis is simply this. Ankylosing spondylitis is a HLA-B27 associated disease. For the most part, it is defined by its involvement of the spine, hence spondyloarthropathy or arthritis of the spine. It is an inflammatory spinal disease, not a degenerative process. It is not discogenic. It is not related to fractures, dislocations, or deformities. It's inflammatory. Ligaments become fused. We develop a bamboo spine. We have sacroiliac abnormalities. We start with pseudo-widening of the sacroiliac joints. And for the record, if you're a rheumatology trainee, do not leave your fellowship until you are comfortable reading your own sacroiliac films competently. I was told by a peer of mine that none of us know how to read sacroiliac films correctly. I firmly disagree with this. Just ask Muhammad Azad Khan, who is a world guru on the topic, semi-retired, but he'll concur with my thoughts that we can very well read our own sacroiliac films, and we do a better job of it than anybody else, because frankly, nobody else even looks at the sacroiliac joints. So, the other things about ankylosing spondylitis, it is a systemic disease, and it does have mimics or differential diagnosis. So the other conditions that mimics ankylosing spondylitis would be to first know that typically ankylosing spondylitis is considered to be bilateral and symmetric within the axial skeleton. Same for Crohn's disease. So in fact, in many cases, you won't know a patient has latent Crohn's disease until they develop the bowel symptoms while being previously diagnosed with ankylosing spondylitis. Now, the HLA-B27 is only positive in about 50 or 60% of Crohn's patients who do have the classic arthropathy, but they also have the ASCA antibodies while the ankylosing spondylitis patients don't. And frankly, Crohn's disease should be proven by biopsy, if for no other reason, because Whipple's disease can mimic the exact same pattern in the spine as the aforementioned diseases. So this is important to know. The other major distractor would be psoriatic arthritis, which is unilateral and asymmetric in the axial skeleton with unilateral sacroiliac involvement and asymmetric axial involvement. So one comment is that typically the thoracolumbar junction is rapidly involved. Squaring of the end plates is noticeable, and then after that the fusion process starts to begin, and the osteophytes, they also would start at that point. That being said, after all these years in practice, I assure you that the disease does not read books, and I've seen psoriatic arthritis in a bilateral and symmetric pattern with fusion of each SI joint, and I've seen Crohn's disease, at least early in its course, with unilateral disease. Of course, we can't predict whether or not the SI joints are going to become involved simultaneously or if one follows the other. This is something that nobody knows. Biologic therapy works terrific, especially infliximab. And while it's not required to use infliximab along with methotrexate, I find that the combination always works better than using infliximab alone. And don't forget the infliximab dosing for the seronegative spondyloarthropathies, which is the heading for the ankylosing spondylitis group, is 5 milligrams per kilogram rather than 3 milligrams per kilogram, which is the rheumatoid arthritis dosing. So I mentioned a couple of mimics. I'll throw in sarcoid is also a mimic. The axial involvement of sarcoid mimics the seronegative spondyloarthropathies. I'll also mention that psoriatic arthritis also has about a 50% positivity of HLA-B27. I'll mention that in the northern latitudes, such as Northern Europe or Alaska, the prevalence of HLA-B27 is exceedingly high, and in certain Eskimo tribes, the HLA-B27 could be as high as 100%, and in equatorial Africa and sub-Saharan Africa, it approaches 0. In the United States, approximately 10% of normal Caucasians are HLA-B27 positive with no disease. This is a very important point, particularly as it applies to sensitivity and specificity. I'm sure I did not answer everything there is to know about ankylosing spondylitis, but I do hope this gave some insight. Be aware that if somebody has ankylosing spondylitis with renal disease, more than likely it would be chronic amyloid, which is very rare. If ankylosing spondylitis affects the lungs, the typical issue there would be apical bullous lung disease, while many other possibilities exist. That would be a common one. And remember, on the boards, they're not going to ask you the common ones. They'd probably say to you, somebody has a fused spine and sacroiliac abnormalities, and they're short of breath. What do you think? That's the type of thing they'd ask on the boards. Hopefully this is informational for the patients as well. Don't miss your medicine. If you have a question about your medications, always call the physician that prescribed the medication. Don't rely on other people. Keep the prescriber accountable for whatever medication he or she has prescribed for you. And if things aren't working out, give a shout out to your family doctor or your prescribing doctor, your rheumatologist, whoever it may be. And if you have more topics for me, just say so, and I'll try to discuss them and answer your questions and keep posting more of these impromptu video sessions. So don't forget, wish me a happy birthday, and keep enjoying the videos. I'll try to keep the political comments out of it since nobody mentioned it. I assume nobody was offended, and that was my goal, to just put across my point of view on a few topics previously. Have a great night. Talk to you soon.